Good afternoon, everyone. Welcome to our webinar organized by the College of Physicians Malaysia. Theme of the month is neurology, and we are very fortunate today to have our chairperson, Professor Dr. Lim Shen Yang. A few words about Professor Dr. Lim. He's a senior consultant neurologist and specialist in Parkinson's disease and movement disorders. He is also a professor in the Division of Neurology in University Malaya. He's the chair of International Parkinson and Movement Disorder Society, Asian Oceanic Section. He has published widely in the field of movement disorders and with special interest in Parkinson's disease. He's committed to teaching and training our future doctors and young neurologists. Without further ado, let us welcome Prof. Dr. Lim.
Thank you, Dr. Calvin. It's nice to be part of this College of Physicians Malaysia educational event. It's a pleasure actually to chair and moderate this session. I would like to invite Dr. Neo Rayjan. Dr. Neo is one of a small but growing number of neurologists in Malaysia with a special interest in Parkinson's and movement disorders. He graduated, I believe, in 2011, and then subsequently finished his internal medicine and neurology training, and then subsequently spent some time, almost a couple of years, in one of the world-renowned centers for advanced training in neurology, which is in London, the National Hospital of Neurology and Neurosurgery at Queen Square. So today, his topic is actually addressing a very common and important problem that movement disorder neurologists and general neurologists see, which is that of Parkinsonian conditions, Parkinsonism, as well as so-called Parkinson plus syndromes. So, Dr. Neo, I hand it over to you. Thank you.
Thank you, Prof. Lim, for the kind introduction. And thank you to the College of Physicians Malaysia for the invitation and the arrangement. I would like to share my slide now. Can you see the slide?
Yes, yes.
All right. So today I've been given this topic, Parkinsonism and Parkinson plus syndrome. It's a topic that's close to my heart. I undergo special training in Parkinson and movement disorder in Queen Square, London. And over there, I witnessed so many different types of Parkinsonian disorders. So here I am to share how to differentiate different types of Parkinson disease. Okay, to begin with, I think we need to understand what does it mean by Parkinsonism, all right? So Parkinsonism is a collection of signs and symptoms, all right? So if you see these signs and symptoms, you can call the patient to have a Parkinsonism. So what are those signs and symptoms? First is the bradykinesia. It's the slowness of the movement and the decremental response in amplitude or the speed as the movement are continued. And you may even see a progressive hesitation and a halt. So the bradykinesia term is not just referring to the speed, but also the amplitude. So we use it, there's another term called hypokinesia, but we use bradykinesia to encompass both of that speed and the amplitude. So it's not just the slowness of the movement, As the movement continued, you can see that the speed reduced and the amplitude getting smaller and smaller. So that's a classical description of the bradykinesia. The next is the rigidity. It's the velocity independent resistance to passive movement, and it's not due to the failure to relax. So from my personal practice, I find that you can do in any joint, you can check the tone in other joint, but I feel the wrist is the best joint to test for the rigidity. So normally a Parkinson patient will be next to you in the clinic, sitting next to you. So you just hold their wrist and you move it, flexion and extension, or turn it around to feel is there any rigidity. You need to feel many patients' wrists to know what is normal tone before you feel the real rigidity in those with Parkinsonian disorder. Finally, the most maybe famous symptoms of Parkinson will be the rest tremor because it's the most obvious. The tremor is at rest, so there's a keyword. So when the patient is not doing anything, sitting down, there's a tremor, and is classically described as 4 to 6 hertz oscillatory movement in the fully resting limb. And when the patient tries to initiate a movement or outstretch the hands, the tremor can be suppressed for a while before it re-emerge, and we call it re-emergent tremor. So I'm going to show that in the next video. So you can see in this video, there's a bilateral rest tremor. The patient hands is on the thigh. So I turn it around, it stops for a while. It comes back. I ask the patient to count backward from 20, 19 to distract her. And in Parkinsonian rest tremor, the tremor get worse when you distract them. You can ask them to count backward, say the months of the year backward, and it will get worse. The classical description for Parkinson's disease is a pill rolling tremor, where the thumb and the index finger has oscillatory tremor. So you can see just now when she put her hand in the outstretch, the tremor stopped for a while, and then it comes back. So we call that re-emergent tremor. In the next video, I ask the patient to do repetitive tapping of the index and index finger and the thumb. You can see the movement is very slow, and as the movement continues, it gets smaller and smaller and even stop. So that's the classical description of the bradykinesia. So this is the definition of Parkinsonism. It's a collection of symptoms and signs that form this syndrome. And this syndrome of Parkinsonism has many causes. So let's define what is Parkinson plus syndrome. It's also known as atypical Parkinsonism. It's a neurodegenerative disorder other than the Parkinson disease with Parkinsonism as the key features. Traditionally, it encompasses the 4 disorders: multiple system atrophy or MSA, progressive supranuclear palsy or PSP, Corticobasal Syndrome or CBS, and dementia with Lewy Bodies or DLB. Each of these is a lecture by itself. So of course, I cannot cover all in this single lecture, but I'm going to just provide the clinical tips and pearls on how to recognize them in your clinic. I understand that my audience mainly consists of medical officer and physician from the internal medicine department. So this lecture is to give you some tips to recognize them. It's not meant to be comprehensive. So I won't be talking about the treatment, okay? Just how to recognize Parkinsonism and how to differentiate from the Parkinson plus. So just to give you an overview, when you detect the patient to have Parkinsonism, there are also secondary causes, okay? It's not just, that the 4 disorders that I mentioned to you just now, the Parkinson plus or Parkinson disease, but there's also secondary causes. For example, vascular, drug-induced, metabolic, autoimmune, paraneoplastic or toxic causes. But today, our lecture is not going to talk about the secondary causes, but you have to think about it in certain selected patients who demonstrate some features that will make you think about secondary causes. And it's important to recognize secondary causes because some are treatable. The patient Parkinsonism can even reverse. So my talk today will be focusing on this Parkinson plus syndrome part, okay, at the top part. So in order to understand what is atypical Parkinsonism or Parkinson plus syndrome, we need to know what is typical Parkinsonism, or also known as Parkinson disease or idiopathic Parkinson disease or IPD. So there's a MDS, Movement Disorder Society clinical diagnostic criteria that was released for Parkinson disease in 2015, which created 2 clinical certainty for clinically established PD and clinically probable PD. So I'm not going to go into the diagnostic criteria for all the diseases because in real practice, we don't really, follow strictly the diagnostic criteria because in a way, the patient normally present with these features and we can say this is Parkinson's disease, this is MSA, this is PSP. This diagnostic criteria is more important for those, for example, the inclusion in the research, or in the clinical trial. You want to select a patient properly. So you want to know that this patient absolutely have Parkinson's disease before you can enroll. But I just want to mention here, to diagnose a PD, a clinically established PD, you cannot have any exclusion criteria, and you need to have 2 or more supportive criteria with no red flags. In probable PD, you cannot have exclusion criteria. You can have red flags, but it needs to be counterbalanced by supportive criteria, but you cannot have more than 2 red flags. So what are the PD supportive criteria? The Parkinson's disease, the patient will show clear and dramatic beneficial response to dopaminergic therapy. There is a presence of levodopa-induced dyskinesia. So if you see a dyskinesia in your patient, even though it's a complication of levodopa therapy, but it's a sign that you are treating the Parkinson's disease and the treatment is working. So if you see a rest tremor, or there's an olfactory loss, or cardiac sympathetic denervation on MIBG scintigraphy, I will explain this a bit later in the later slide. What are the green flags? So it's not just red flags. So what are the green flags that will make you say that this is more likely to be a Parkinson's disease? If you have a tremor that is unilateral in onset, which is at rest, pure rolling in character, the upper limb will be more than the lower limb. And there is a bradykinesia, rigidity, with some slowness on walking, shufflings, poor balance, and the progression will be gradual. The response to levodopa will be excellent. The cognition is usually preserved or may be impaired at the late stage, and the autonomic symptom will be mild to moderate. So this is how a typical Parkinson disease will present to you, which is the majority of the cases. So what are the absolute exclusion criteria that if you see this in the patient with Parkinsonism, you say this is not Parkinson's disease? So unequivocal cerebellar abnormalities. If you see a Parkinson with cerebellar abnormalities, you don't call it Parkinson's disease. It could be something else. So if you see a downward vertical supranuclear gaze palsy, you can see a behavioral variant of frontotemporal dementia or primary progressive aphasia within 5 years. Or if it just involved the lower limbs for 3 years, or if the patient is on any dopamine blocker, all right, or any absence of good response to levodopa. If the patient have any cortical sensory loss, such as aggraph-esthesia, you try to write a alphabet or numbers on the patient's palms and ask the patient to say what letter or number that you write, and patient not able to tell. Or if you give an object that patient cannot name in his hand, so there is a cortical sensory loss with the intact sensation. So when you test the sensation, it's normal, but they cannot name the object that's in their hands. So there is cortical sensory loss. It's an exclusion criteria for Parkinson's disease. Or if you do the functional presynaptic dopaminergic system neuroimaging, or in short, they call it DET scan, if it's normal, it's an exclusion criteria as well. Or if there's any alternative condition that produces Parkinsonism. What are the red flags? So if you remember, the red flags maximum can only present 2, but must be balanced by the supportive criteria. Means in Parkinson's disease, they could have this as well, but maximum you give them 2. So what are those red flags? There's a rapid progression of gait impairment, requiring wheelchair within 5 years. There's a complete absence of motor progression over 5 years, means the patient stays static for 5 years. So you might be thinking of something static like vascular causes. Early bulbar dysfunction, such as severe dysphonia, dysarthria, or dysphagia within 5 years. There is an inspiratory respiratory dysfunction, severe autonomic failure within 5 years. Recurrent falls due to impaired balance within 3 years. There's an abnormal posture of contractures. Or after 5 years, there is no non-motor symptoms like sleep dysfunction, REM sleep behavior disorder, autonomic dysfunction, hyposmia, or psychiatric abnormalities, then it's also a red flag. If there's an unexplained pyramidal tract sign, that you see there's a hyperreflexia or the plantar is upgoing, so this is not seen in Parkinson's disease. or the Parkinsonism is symmetric throughout the disease course is also atypical for Parkinson disease. So in the Parkinson disease natural history, they can begin with non-motor symptoms like constipation, REM sleep behavior disorder, up to 20 to 10 years before the development of the motor symptoms. So when they develop the motor symptoms such as bradykinesia, rigidity, tremor, it takes a gradual course 10 to 20 years before the complication sets in, like dysphagia, instability, freezing, psychosis. So it's an indolent disease over the years. So this is how a Parkinson disease patient looks like. So it started unilateral rest tremor. This patient was initially misdiagnosed to have essential tremor. So the patient put the hand outstretched, there's no tremor, and it come back. So there's a re-emergent tremor. It's a peculiar feature that is more commonly seen in Parkinson disease rather than other Parkinson plus syndrome. And when the patient walks, you can see there's a reduction in the arm swing on the right. The left hand is still swinging. And when the patient is walking, you can see there's a tremor on the right hand. In a way, walking is a form of distraction as well. So you can see the tremor on the right hand when the patient is walking. So this is the typical Parkinsonism. Okay, next, I will go to the first Parkinson plus syndrome, multiple system atrophy. It's a progressive neurodegenerative disease with Parkinsonism, cerebral syndrome, and autonomic failure in various combinations. Neuropathologically, you can see an alpha-synuclein positive glial cytoplasmic inclusion or GCI and a neuronal loss in the striatonigral and olivopontocerebellar systems. It's a progressive disorder, more than 30 years old, and come in a sporadic fashion. So there should not be any family history to diagnose an MSA. The prevalence is about 3 to 5 in 100,000 population, and is divided to two, MSA-P for Parkinsonism and MSA-C for cerebellar, depends which feature is predominant. And the mean disease duration is about 8 to 10 years. So if you compare just now with the Parkinson disease, up to 20 years, MSA is shorter. So this neuropathological sample show a glial cytoplasmic inclusion, alpha-synuclein positive glial cytoplasmic inclusion in the striatonigral and olivopontocerebellar systems. So you need to have this to be really certain that the patient has MSA. So in 2022, the MDS released a criteria, multiple system atrophy, and they divide into four. A neuropathologically established MSA. So from the histopathological sample just now that you see, we call it neuropathologically established. But you know, most of the patient won't be able to be diagnosed in such a way. So we need to diagnose them clinically. So we try our best to diagnose a clinically established MSA. If not, we go to probable or possible prodromal. This is more for the research setting. So what are the core clinical features to say this is MSA? So they must have Parkinsonism, which is usually symmetric. They are usually tremulous. They develop early postural instability and freezing of gait, and they have a poor levodopa response. They can have cerebellar ataxia, which is divided into four: the gait, the limb, the dysarthria, and the oculomotor dysfunction. And they have autonomic dysfunction. There are many symptoms of autonomic dysfunction, but in the criteria, there are two most important part is the drop in the blood pressure, more than 20 systolic and 10 diastolic after the patient stand for 3 minutes. And in terms of the urinary difficulty, in the form of urge incontinence, post-void urinary residual, or PVR more than 100 ml as determined by the ultrasound. So in a way, patient had the urinary retention after voiding. In a male, they invariably have erectile dysfunction and other autonomic symptoms such as constipation, gastroparesis, reduced or absent sweating will be there. So what are the supportive motor features to diagnose an MSA? So in contrast with PD, it's a rapid progression, moderate to severe postural instability, and there's a peculiar feature in which they have the cranial cervical dystonia, and it's usually induced or exacerbated by the levodopa treatment. So if you give them levodopa, they can have the jaw clenching and they looks as though they are smiling like a rhizosyndonicus in the absence or minor limb dyskinesia. Okay, so in Parkinson's disease, they have dyskinesia of the limb, but in MSA, they have, in a way, dystonia of the face. They have severe speech impairment within 3 years with dysphagia and unexplained Babinski sign. And they also have this peculiar jerky myoclonic posterior or kinetic tremor. When they put a hand outstretched, the hand did not just having a tremor, which is oscillatory movement, but is jerky in quality. We call it also as polymini myoclonus, which is also seen in other disorder like neuropathic disorder like motor neuron disease or Hirayama disease. Postural deformities is also common in MSA, which I will show in the next slide. It's been described as disproportionate anticolis. So in Parkinson's disease, you do have some anticolis as well, but in MSA, it's disproportionate. They can also have the lateral bending, or we call it as Pisa syndrome, or even severe flexion of the trunk. We call it camptocomia. There are also supportive non-motor features, such as stridor, inspiratory sign, cold discolored hand and feet, just as the one in the picture here, because of their poor circulation and autonomic dysfunction, erectile dysfunction, and they may have pathological laughter or crying. In a way, is also known as emotional irritability. They have certain MRI brain markers, such as atrophy of this strategic structure, namely putamen, middle cerebellar peduncle, pons, cerebellum. You may see hot crossband sign, and in the diffusion scan, you can see increased diffusivity of the putamen and middle cerebellar peduncle. So in MSA, is putamen, pons, and middle cerebral peduncle with cerebellum. So if you see this picture, the first number 1A, they show there's a pontine atrophy with cerebellar atrophy. You can see there's an increase in the fissures and folia, and there's a dilated in the fourth ventricle because of the atrophy of this structure, compared with the B, which is a patient with Parkinson's disease. So the pons volume and the cerebellar volume is normal. In the picture number 2A, you can see there's a atrophy of the middle cerebellar peduncle, the straight arrow, and the atrophy of the cerebellum, the one that been demonstrated behind. In comparison, for those with PD, in the picture B2B, the MCP is preserved in volume. Number 3 is the picture of hot crossband. You can see there is a cruciate hyperintensity in the pons, but this is not the early sign. Normally, this comes a bit later. So even if you cannot find hot crossband, does not mean that the patient don't have MSA. If you see the 4A, 4C is normal. You can see 4C first, the putamen, a bit brighter color. And you compare with the A, there is a loss of putamen, putaminal atrophy, so it becomes hypointense instead. And on the outer part, I cannot put the laser when I'm zooming. So, and the outer part of the putamen, there's a hyperintense rim. Okay, you can see the putamen is black color and hyper-intense rim of the outer part. The second picture, 4B, also show putaminal atrophy with increase in the hypointensity. In 5A, you can see there's a hyperintensity at the pons level over the middle cerebellar peduncle. Okay, there's a hyperintensity over there. It's called MCP sign. In contrast, the MCP is normal. 6A is a diffusion scan. If you look at the 6C, at the area of putamen, the color is grayish throughout. But in 6A, there is an increase in the brightness, and 6B as well. So there's an increase in diffusivity in the diffusion scan in patient with MSA. And lastly, in the picture number 7, this is the iron sensitive scan, or sometimes SWI, they call it. You can see that there's iron deposition or subset blooming artifact at the typically dorsolateral part of the putamen. So they produce this hypointensity in the picture A and B, while C, there is no iron deposition at the posterior part of the putamen. So if you see all these imaging features in a patient with Parkinsonism, you expect MSA as well. So if you remember just now, we talked about PD natural history. For MSA, they develop Parkinsonism, cerebellar features, and the complication come fast within 6 to 9 years. So the time is shorter here, and they can develop the complication from immobility such as bronchopneumonia. They may need tracheostomy, gastrostomy, and death from pneumonia of sometimes autonomic dysfunction. So this is a big video of a patient with MSA. So there's some jerky tremors on the hands. There's a jerky tremor of the fingers. So when I ask the patient to tap the fingers, it's very slow, interrupted, not smooth. In the finger nose test, there is a finger nose ataxia. As the head approaches the finger, there's an intention tremors, and there's also a swaying in quality when you try to reach the objects. So there's a limb ataxia. So the left hand is okay, but the right hand is more affected. You can see there's a dysdiacokinesia on the right. There's a difficulty with the alternating movement. I asked the patient to say some words, if you can hear.
Persatuan Peladang-Peladang Pulau Pinang. Persatuan Peladang Pulau Pinang.
So there's a cerebellar dysarthria as well. So when the patient walks, there's a freezing, the gait is broad, ataxic. Turning in multiple steps. So this is a patient with the MSSC, with the predominant cerebellar features, and the brain that shows hot crossband signs with the atrophy of the cerebellum, and there's a bright MCP as well, MCP sign. Okay, so next I will be going to progressive supranuclear palsy. So it was first described in 1964, also known as Steele-Richardson-Orzechowski syndrome. It's a bit more common than MSA, 6.9 per 100,000 populations. And neuropathologically is different from MSA. It's a 4 microtubule binding repeats of 4R tauopathy, in which you can see a tufted astrocyte and globus tangle. The criteria is the patient must be aged more than 40, is sporadic and with gradual progression. So in a way, MSA is a bit younger. MSA is about 30 to 50. PSP is a bit older, 40 to 60. And Corticobasal Syndrome is even older, like 50 to 70. So this is the tufted astrocyte that you can see in their neuropathological samples, and this is the globus tangle. So there's also a MDS diagnostic criteria for PSP, also divide into 4 parts: neuropathology confirmed, probable, possible, and suggestive. They are quite complicated way to categorize them, where they divide into level 1, 2, 3 with 4 important domains: oculomotor dysfunction, postural instability, akinesia, and cognitive dysfunction. There are supportive features as well. And with that various combination, you can label it individually, like PSP Richardson syndrome, PSP frontal, PSP Parkinsonism. So I think we are not going to go into here. I think it's important at this time to how to recognize PSP first. So the core clinical features is they have an early posterior instability of falls within 1 to 3 years. In fact, if you ask which one among all those Parkinson plus and Parkinson disease, which one will fall first? It's PSP. It fall within 6 months. And MSA and CBS is about 1 to 2 years, while in Parkinson disease, the fall is after 5 years. So PSP will fall first. Okay, so if your patient have Parkinsonism with early fall, think of PSP. And when you examine their eyes, you might find there's a slowing in the vertical saccades and eventually supranuclear gaze palsy, and they may develop progressive gait freezing early within 3 years. There are other supportive features. Importantly, the eye signs. There will be staring appearance, blepharospasm, apraxia of the eyelid opening, and square wave jerks with problem with the vertical eye movement. So in contrast to MSA and PD, they are looking forward anticolis, but in PSP is retrocolis. So the head is extended backward. So they may also have purposeless groaning. Prof. Lim has written a report on this. And they may have rocket sign in which they clumsily trying to stand up from sitting without cautions, and they fall back to the chair. So that's called rocket sign. And the way they walk has been described as drunken sailor. And they also can have messy thigh sign. This sign refer to when they eat, because of the vertical gaze dysfunction, they cannot see their food properly. So the food stain the thigh. So this is the video of a patient with PSP. So horizontal eye movement is okay, but the patient can't look up and down. There's a severe limitation of the up and down gaze. You see there's a retrocolis. He's looking backward, extended neck. The trunk is also extended. That's why they actually fall backward rather than fall forward. So if your patient fall backward, think of PSP. So they try to assess for the postural instability, and they will fall down behind like a log. So there's an early postural instability in PSP. This is another video to show the supranuclear gaze palsy. So if you passively move the patient head, the eye can actually move side to side, but also up and down. You can see that the examiner struggle to flex the neck because in PSP you have axial rigidity. So when the examiner extend the neck, the eye can actually look down. But when you ask the patient to look down, he can't look down. So this is supranuclear gaze palsy. In the imaging, so just now in MSA, the structure involved is the pons, the cerebellum, the putamen, but in PSP, the structure involved is the midbrain. So midbrain is also the center for our vertical gaze. So there's a tapering of this midbrain that looks like a bird. So it's called as hummingbird sign. In the axial view, it's sometimes known as morning glory sign as well. There is also atrophy of the superior cerebellar peduncle. So you can see that there's a concavity here. And because of the atrophy of the midbrain, the third ventricle will look dilated in the MRI. Next, we are going to the Corticobasal Syndrome. Among all the Parkinsonian disorder, this is the rarest. So it's a gradual progression, more than 50 years old, sporadic as well. Prevalence is about 1.3 in 100,000. It's also a 4R tauopathy, just like PSP. And that's why there could be an overlap with other tauopathy like PSP, Alzheimer's disease, or even frontotemporal dementia. You can see this hyperphosphorylated 4-repeat tau in the astrocytic plaque formation. So this is an astrocytic plaque. Again, we also have a diagnostic criteria for corticobasal degeneration. This is published in 2013, so already 12 years ago. Because it's a rare disease, the report is coming a bit less for corticobasal syndrome. This is published in the Neurology journal. So the criteria for the motor features include, we mentioned just now in Parkinson's disease, it should be unilateral, but in corticobasal syndrome, it is almost strictly unilateral. So it's too unilateral that it's become too abnormal. So the patient has an asymmetric Parkinsonism with dystonia, in which they could have abnormal posture of the hands or limbs. They can have myoclonus. They can have oral buccal or limb apraxia. So apraxia is defined as the difficulty to perform motor tasks despite normal strength. So what do we normally do is we ask the patient to copy the finger gesture, such as you ask to do like this or like this. And normally they will have difficulty to copy the finger gesture. So that's called as idiomotor apraxia. They may also demonstrate a sign of alien limb phenomenon, in which the limbs on one side of the hand feel foreign, as though it does not belong to them, and may even move by itself. So can you imagine you have a body part of yours that's not listening to you and have a mind on its own? So that's called alien limb phenomenon. And they may have cognitive and behavioral features as well, in which they can have cortical sensory loss, such as xerognosis and agraphesthesia. If you remember this just now, is in the exclusion criteria for PD, is referring to this CBS disorder. So they can have executive dysfunction, non-fluent aphasia, in which it's getting more and more difficult for them to speak until they will become mute, like how aphasia patient behave, those with MCA stroke. They may have visual spatial deficit and behavioral changes such as apathy, irritability, such as resembling a frontotemporal dementia. So this is a patient with the CBS. I want you to focus on this right hand, in which is forming a posture. So this abnormal posture is unilateral limb dystonia that's seen in CBS. So they can perform tasks with the left hand, but it's difficult to do anything with the right hand. There's another patient, can see a severe dystonia on the right hand with abnormal posturing. The thumb is got trapped in between the fingers. So in a way, a CBS, when they come to see the doctors, the chief complaint might be different from those with Parkinson's disease. In Parkinson's disease, they come with tremor, they come with slowness, they come with change in their walking, become more shuffling, then handwriting becomes small. But in CBS, is more of, I cannot use my hand. My hand become useless. I cannot write anymore. I cannot eat with my right hand anymore. So the chief complaint is different. So if your patient complain that their hand become useless, so think of CBS. And in the imaging, contralateral to the affected limbs, for example, if you have a right limb Parkinsonism and dystonia myoclonus, the left side of the brain will be more atrophy than the right side. So the finding that you should look for in CBS is asymmetrical atrophy. And finally, we go to the last Parkinson plus syndrome, dementia with Lewy bodies. In a way, this is a spectrum of Lewy body disease. So the Lewy body disease also include Parkinson's disease. It's just that this Lewy body, it got deposited in the different structures. So in Parkinson's disease, it's more in the striatonigral structures around the basal ganglia and the midbrain. But in DLB, it got deposited around the cortex. So it caused early dementia. So there's progressive cognitive decline interfering with the daily functions, mainly in the attention, executive, and visual perceptual function. The memory will be spared initially, but will be affected at a later stage. So if you suspect a patient to have a DLB, they also have other core clinical features such as fluctuating in the cognition. So the patient might be quite well, normal, speaking well in the morning, but in the evening, they look confused, they look drowsy. So there is a fluctuation in the cognition. They will have vivid visual hallucination as well. So in the hallucination, for example, in psychiatric patient, they may see shadows, they may see some illusion of the lights. But in those with DLB, they can actually see a well-formed, detailed structures. For example, they can see a human, the children, or the animals running around. This is more in keeping with the DLB rather than other psychiatric disorder. And they have Parkinsonism as well, which is quite similar to Parkinson's disease. So it can be unilateral, they can have pill rolling tremor as well, they can have shuffling gait and everything. But there's an early involvement of the cognition with the REM sleep behavior disorder, as is also part of the Lewy body disease. There are other supportive clinical features for DLB include, in a way, they are the most severe form of Parkinson's disease. In fact, if you allow the Parkinson's disease to progress, after 20 years, they develop dementia, it's actually indistinguishable from the DLB. They may also have vivid hallucination. They also have dementia. They also have instability and everything. In fact, if you take their brain, Parkinson's disease with dementia and those with DLB at the later stage, they look the same. So in a way, this is just a spectrum of the Lewy body disease. So they're also prone to have severe autonomic dysfunction, and they can have also hallucination in other modalities such as auditory. So there are biomarkers that can help us to diagnose DLB. In a way, when you have a patient with dementia, you want to ask yourself, is this DLB or is this Alzheimer, which is the most common cause of dementia? So you can do this dopaminergic transporter scan or DET scan. In DLB, because it's a Parkinsonian disorder, the DET scan will be abnormal. But in Alzheimer, the DET scan will be normal. The DLB will have abnormal MIBG myocardial scintigraphy, and also will have REM sleep behavior disorder, which is confirmed by the polysomnography, the sleep study. So the first picture, this is a cardiac scintigraphy, the 123 iodine MIBG. In those with normal control, there's an uptake of the radio label norepinephrine. Okay, so it's at the peripheral autonomic system in the postganglionic. The radio label norepinephrine will be taken by the heart. But in those with DLB or even Parkinson's disease, there is a peripheral autonomic dysfunction. So there is no uptake of these radio labels norepinephrine, so it's absent here. So it will be present in Alzheimer's disease. So it's a good way to differentiate between DLB and Alzheimer, but it will be the same for DLB and PD. So you cannot differentiate that too. But you can differentiate it from MSA. So PD or DLB versus MSA. The MSA MIBG scan will be normal as well, because in MSA, it's not peripheral autonomic dysfunction, it's a central autonomic dysfunction, where the structure involved is brainstem and the spinal cord. This is a DET scan. In normal patient, you can see this comma shape, but in those with Parkinsonian disorder, there will be loss of this uptake in the basal ganglia. And logically, it will be normal in Alzheimer's disease. This is a sleep study in which the patient has a REM sleep now, rapid eye movement phase of the sleep. So you can see the eye is moving. EOG is electrooculogram. In the EMG, the chin, the legs, it should be quiet. So this is normal person, all right? But in those with PD or DLB with Lewy body disease, during the REM sleep, their muscle is moving as well. So they tend to shout, move, or acting out their dream during the REM sleep phase during their sleeping. So other supportive biomarkers such as low uptake in the SPECT scan, and in the FDG pad, you may see a sign called cingulate island sign. So this is the metabolism map with the specs. You can see in normal control, the red color means is normal metabolism. But in those with DLB, there is a more severe involvement of the occipital lobe. But if you see in Alzheimer's disease, they affect frontoparietal-temporal lobe with relative sparing of the occipital lobe. So you can do this to differentiate between Alzheimer and DLB again. So in this FDG pad, in DLB, it tends to spare this structure called posterior cingulate. So it's known as cingulate island sign. Could be useful. In MRI, there is a, in the normal control, you can see the medial temporal lobe is normal. In DLB also relatively spared. Of course, it won't be normal, but some atrophy can be seen. But if you see in the Alzheimer's disease, this is a disease that affects the medial temporal lobe the most. So MRI can be helpful to differentiate as well. So I come to my summary. So it's important to first recognize Parkinsonism, the bradykinesia, the rigidity, the tremors. And you suspect PD if it's asymmetrical in onset, gradual progression, good response to levodopa with dyskinesia. You suspect MSA when the Parkinsonism is symmetric with cerebral sign and autonomic dysfunction. You suspect PSP if the patient has Parkinsonism with early fall and there's a vertical gaze dysfunction. CBS if it's a unilateral Parkinsonism with other movement disorder like dystonia, myoclonus, apraxia, and cortical sensory impairment. And you suspect DLB if the patient has Parkinsonism with dementia, vivid hallucination, and fluctuating in their cognitions. So thank you so much.
Thank you, Dr. Neo, for your comprehensive coverage of these, quite challenging conditions to sometimes to diagnose and also to treat. So there are a few questions, not that many, because I think your lecture is already very comprehensive. There's a question here from Dr. Shi Jiaping, who asked whether there have been identified genetic variants manifesting as atypical Parkinsonism phenotypes.
Yes, they do actually. So, but in the diagnostic criteria, they try to put that, for example, MSA and PSP to be a sporadic disorder, but more and more genetic has been found that has been identified that can present as like a PSP or MSA as well. So for example, the MAPT gene mutation can have PSP phenotypes. Even in the LRRK2, LRRK2 can have a PSP phenotype. So more and more genetic variant has been identified to manifest with atypical Parkinsonism phenotypes.
That's right. Thank you, Neil. Yeah, in fact, last year we published together with our Singaporean colleagues on genetic variants in PSP, and exactly as you say, MAPT gene and various other genes as well that have been implicated in overlap conditions like FTD, frontotemporal dementia, ALS or motor neuron disease, even Parkinson's disease. There are some shared genetic variants, like you said, in LRRK2, which is a recognized gene that contributes to a significant number of PD patients. There's a question here from Anonymous. I think maybe don't spend too much time on this because this person asked, can you explain again the definition of Parkinsonism? Because I think they probably miss your first couple of, so maybe just in a nutshell, like 30-second answer for them.
Okay, so Parkinsonism is a collection of signs and symptoms. It's a syndrome actually. So like how anemia is, and the cause could be iron deficiency from bleeding, right? So Parkinsonism is just a syndrome. So how do you call a patient to have a Parkinsonism is when they demonstrate bradykinesia, which is a slowness and decremental response in amplitude and speed. They have rigidity as well, which is the passive resistance to movement. And they may have rest tremor, which is tremor when the limbs is at rest. So if you see the collection of these features, you can call the patient to have Parkinsonism and try to find out what are the causes, which could include Parkinson disease and Parkinson plus syndrome.
Yeah, that's great. Can I ask, Neil, what, of course, your lecture is focused on the differential diagnosis of these conditions. And as you rightly said, some of these conditions by themselves can be a separate lecture. But can you briefly outline what are some of the, treatment approaches you would take to patients with these conditions?
So in all the Parkinsonian disorder that I mentioned just now, Parkinson disease and all the Parkinson plus, there is still now no cure or disease-modifying treatment. So the symptoms are all symptomatic. So for the motor symptoms, in all, I think we should still try levodopa. So levodopa is the dopamine replacement because in most of the pathophysiology, there's a reduction in the dopaminergic producing neurons. So levodopa can be given for the motor symptoms. And for other part of the symptoms is as per the symptoms. For example, if you have a constipation, you give them laxative and lifestyle advice. If they have a mood disorder like depression and anxiety, they may respond to SSRI. If they have autonomic dysfunction such as autonomic hypotension, orthostatic hypotension, we can give them lifestyle advice, for example, drinking waters, salt intakes, abdominal binder, or trial medication like fludrocortisone and midodrine. So it's a long thing. So they are mostly symptomatic based on the patient, what the patient has.
Yeah, thank you, Neil. Yeah, and also, of course, not to forget input from our allied health colleagues in terms of things like physiotherapy, prevention of falls, or if patients are falling, minimizing injuries, and then things like speech and swallowing therapy, right, to address complications like aspiration pneumonia and communication issues as well. There is a question here. It's interesting. This person says, again, anonymous, may I know if levodopa should be started immediately upon suspecting Parkinson's or these conditions clinically? For example, in a limited resources setting, because as far as I know, in Malaysia, there's no problem accessing levodopa even in the clinic kesihatan or the district hospital. So I don't think that should be a major issue. It's more in terms of a clinical judgment. So, Dr. Neo, do you have a response to this? When would you start levodopa in these conditions?
As there's no disease-modifying treatment. So levodopa is a symptomatic benefit. So if you have a trouble to decide whether this patient need levodopa or not, most of the time it's because it's mild, it's very early. So you need to ask the patient, is the symptom bothersome? If it is, you can try. In fact, it's quite well tolerated. There's no harmful effect it's quite well tolerable. You can stop if it's not Parkinsonism. But if the patient is quite okay, they're willing to wait, it's not too disabling, you can go for further tests, you can withhold for a while. Because even if you start early or you start late, it does not affect the disease progression. Because a lot of patients, they don't understand, or they have a misconception that if they start late, the disease is going to progress faster. Or if they stop, the disease will progress faster, which is not true. The treatment is just symptomatic benefits. So, or sometimes, if you can follow up the patient yourself, you can also use it as a diagnostic possibility. You suspect the patient to have Parkinsonism. You can give them a trial of levodopa, and you can see back if they respond to it. In a way, if you can see my earlier slide that the response to levodopa is also one of the important features in Parkinson's disease.
Thank you. I would agree with that. I guess with the caveat that although levodopa may not be strictly, neuroprotective or disease modifying at the cellular level, but in terms of patients, if sometimes if they become because of bradykinesia, rigidity, and so on, very inactive, then sometimes that sets up a vicious cycle, right? Where that leads to greater inactivity, then the inactivity worsens the Parkinsonian features and so on. So there can be a modifying effect, I guess, on the patient's condition, although not necessarily maybe at the cellular level. There are lots of questions now coming in, but we have only I think a couple of minutes left. Maybe we can go to a topic that is a favorite of mine, which is a person here asks, anonymous, any role for deep brain stimulation or DBS in Parkinson plus syndromes?
I think in terms of the literature, mostly the selection of the patient for DBS will be from those with Parkinson's disease, and it's well known, well documented, and even from our personal experience, DBS is really helpful for those with Parkinson's disease. And unfortunately, for those with Parkinson plus, they respond poorly to DBS. So in a way, how do we even select the patient for DBS? Normally, we choose based on their levodopa response as well. So we may admit the patients, do a levodopa challenge test, and if there's any improvement in the motor symptoms after the levodopa. But in those with Parkinson plus, generally they have poor response to levodopa. So the response to DBS also will be poor.
That's great. That's great. Thank you. I completely agree with what you say there. Parkinson patients can often respond, but again, they need to be selected. So patients who have, specifically troublesome motor response complications, on-off fluctuations, dyskinesias, and sometimes tremor as well. So I think we're almost at the, at 4 p.m. If I can just, I guess, wrap up and then hand over to Dr. Kelvin to say thank you to Dr. Neo for this nice presentation. And sorry, I meant to say in the introduction that now Dr. Neo, after many years of good service at Hospital Kuala Lumpur, has taken up a very busy job in Asunta Hospital in Petaling Jaya. So if you have patients with these difficult conditions, this is one option that you can consider to refer patients to Dr. Neo. Thank you. I hand over to Kelvin.
Yeah, sure. Thank you, Dr. Neo, for the wonderful talk, and Prof. Dr. Lim for chairing the session. Thank you, everyone, for participating, and we will see you next week. Goodbye.
Thank you. Bye-bye.
Thank you, Prof. Lim. Thank you, everyone. Thank you, Kelvin.